My name is Brooke. I'm a pediatric oncology nurse practitioner, and today I want to talk to you about one of my favorite things to talk about, which is tumor lysis syndrome. So first, let's start with the definition. Tumor lysis syndrome is a metabolic condition where there is a rapid breakdown of a large amount of malignant cells that release their intracellular metabolites, the things that are inside the cell, into circulation. So they become extracellular. And we're going to get more into that as we keep talking. So who's at risk for this to happen? So when a patient is newly presenting with acute leukemia, they're at very high risk. So a patient with B-cell lineage leukemia, T-cell lineage leukemia, AML, T-cell lymphoma, Burkitt's lymphoma, any chemosensitive malignancies, so malignancies or tumors that are going to melt or shrink quickly when you give them chemotherapy. Those with a high tumor burden is another way that we describe it, or a patient with hyperleukocytosis. So hyperleukocytosis is a white blood cell count greater than 50,000, okay? And another little tip that I like to give is that let's say you're a nurse coming in to start your shift and your patient is a newly diagnosed lymphoma patient and they're getting a prophase or a pre-phase of treatment. And you look at it and they're getting 1 week of treatment before they actually start induction. And in this 1 week, there's like a lower dose of steroids, a little bit of vincristin, and a small amount of cyclophosphamide or Cytoxan. That little bit of chemotherapy is given to them because we're trying to prevent them from having raging tumor lysis syndrome by giving them full doses of vincristin or full doses of Cytoxan or steroids. So anytime you have a patient who's getting a pre-phase or a prophase, you need to think about what? Tumor lysis syndrome. All right. Another thing to really consider too is that when we start steroids on a new leukemic patient with B-cell or T-cell leukemia, those steroids are lymphocytoxic. So they are toxic to lymphocytes and they're going to cause those bad malignant lymphoblasts to break up and divide. So those are all things for you to kind of think about when you think about who's at risk for tumor lysis syndrome. So I made this little chart to help you understand. And in the middle here, I have a tumor cell. And when that tumor cell breaks up and divides, you have things that are inside the tumor cell that come out and they go from intracellular to extracellular. So the first thing right here that I have is potassium. So potassium is going to come out of that cell, okay? This could happen when treatment starts, or it could just happen from spontaneous lysis. So potassium is the first thing, and then I put nucleic acids or RNA or DNA. So all that RNA and DNA that's inside of those malignant cells, that's going to come out. Then I have phosphorus here, that phosphorus that's inside the cell. And one thing to keep in mind is that malignant cells have like 4 times as much phosphorus inside of them as a typical cell does. So that's really important to keep in the back of your mind. As that phosphorus goes up, the calcium is going to come down. They have an inverse relationship. We're going to talk a little bit more about that too. Okay. All right. So I want to move on to the signs and symptoms. So what kind of things could you be seeing in your patient? So I made another little chart here. You could see nausea, vomiting, diarrhea, anorexia, lethargy, hematuria, cardiac dysfunctions, renal failure, seizures, muscle cramps, tetany, heart failure, or syncope. Those are things that you might see with your patient. So I think that the easiest way to talk about treatment is to kind of go through each of the things that comes out of the cell and talk about what can we do to kind of counteract each of these metabolic electrolyte disturbances, okay? So the first one is let's talk about the uric acid first. So when all that RNA and DNA comes out, eventually it will be changed and you'll end up seeing it as an elevated uric acid in your patient's blood results, or hyperuricemia. So the first thing that we're going to do to actually treat all of these things, and I'm going to say this about 5 more times, is hydration, hydration, hydration. And usually that's more than 1 times maintenance. Oftentimes it's 2 times maintenance IV fluid. And we're going to talk about that a little bit more too. So besides IV fluid and keeping track of your patient's lab results and keeping track of their intake and output, you need to make sure they're having adequate urine output. So even if the doctor doesn't write for you to have a certain amount of mLs per kilo per hour of urine output for your patient, I would recommend that your patient has urine output at least every 4 hours. That means the middle of the night too. That means even if they're sleeping. That means you might have to wake them up and ensure that they have urine output. And if they can't, then we might end up having to give diuretics. So talking about medications that can help with uricemia, there's 2 medications that we tend to use. One is allopurinol and one is respiricase. Allopurinol is given orally 2 to 3 times a day. It's pretty cheap and it works in a different part of the cycle than respiricase works. So when you take allopurinol blocks the catabolism of hypoxanthine to xanthine. So allopurinol comes in right here. So it's really effective for preventing further uric acid to accumulate when your patient is having either spontaneous lysis or starting treatment and then having lysis. But it's not going to do anything if your patient comes in with a uric acid to start of like 10, 11, 12, 14. That's a job for respiricase. Now, respiricase is given IV. It's very expensive, but it's super effective. And sometimes just within 1 dose of respiricase, you can bring a very high uric acid down to less than 0.5. Respiricase breaks down uric acid, so it comes in down here, and it breaks down uric acid into a more soluble form of allantoin. And that will help to get that excreted. So they work in a different part here with this high uric acid, and they work in different ways, and it's really important that we understand that. Now, when talking about IV fluids, years ago, we used to put sodium bicarbonate in our patient's IV fluid because we know that uric acid tends to precipitate in an acid environment. So we thought, well, if we put sodium bicarbonate in our patient's IV fluid and we make the urine alkaline and we monitor their urine pH to make sure it's alkaline, we're not going to form these crystallizations from the high uric acid. Well, unfortunately, there's not really a lot of good data to support urinary alkalization to prevent these crystallizations from happening. The more important thing is that you have just adequate hydration and adequate output. And on the flip side, as our phosphorus increases and can potentially bind with the phosphorus, that calcium phosphorus binding can actually be more damaging to the renal tubules. And that is better excreted when the urine is acidic. So if we're alkalizing the urine to try to prevent problems from the increased uric acid, we could actually be running into more problems with this alkaline urine with the calcium phosphorus. So that brings us into phosphorus and calcium. For treatment for high phosphorus, occasionally you will see phosphorus binders used. They're not super effective. So we're going to go back to what's our number 1 treatment: hydration, 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 and ensuring that your patient has adequate urine output. We would only give calcium for a very low calcium if your patient was having significant symptoms. They're having tetany, they're having seizures, they're having cardiac arrhythmias. And if you have to give calcium, it should really be at the lowest dose. Why? Because as that phosphorus is climbing up, your calcium, even if it's only at 6, could go up even further when you add supplemental calcium. And if you have a calcium, let's say of 8, and you have a phosphorus of 8, that's going to give you a calcium phosphorus product of 64. Anything over 60 or 70 for a calcium phosphorus product is going to increase your risk of an acute kidney injury and having some significant problems. And even though dialysis is definitely an option for these patients with significant tumor lysis syndrome, we don't want it to have to get to that point. So, moving on to potassium. We know that one of the biggest risks for having a high potassium is cardiac arrhythmias. So there's a potential that your patient might have to go to the pediatric intensive care unit or the intensive care unit to have telemetry monitoring. Sometimes we will use glucose and insulin to help pull that potassium that's extracellular back into the cell and make it intracellular. Hydration, like I said, is the number one most important thing that we can do. And when we're talking about IV fluid or hydration, what's very, very important is that we never add additional potassium chloride to our patient's IV fluid. Even if that patient comes in with a serum potassium that's like 3 to 3.5 from the beginning, and the resident might say to you, why don't we just put a little potassium in there? They're kind of low. You're gonna say what? You're gonna say no, because that patient eventually, as they start having more lysis, could have a real fast elevation of their potassium. So we're going to keep monitoring labs. Another thing we could do is give our patient a low potassium or a low phosphorus diet. And like I said, eventually we might need to have dialysis. So things I want you to consider for nursing, and we talked about these briefly, is strict, frequent intake and output along with weight measurement, frequent lab monitoring, and sometimes that means that you need to be really on top of your labs because the lab might not necessarily call you with a critical value of all the important numbers. In our lab, they might call for a potassium of 5.1, but when a patient has a uric acid of 14, you might not get a call at all. And that's why it's really important for you to go in there and see what your patient's lab results are and report those. Also, reporting any symptoms of electrolyte dysfunction to the medical team. And the last thing that I have here is understanding the pathophysiology of tumor lysis syndrome so that you can teach your patients and their caregivers. Thank you for joining me today. Until next time.